The OLIF51 procedure is an oblique lateral approach to the L5-S1 disc space. When the patient is positioned laterally, the abdominal contents fall forward, so less retraction is required to access the spine. Compared to a traditional ALIF, the patient benefits from an incision that is outside the rectus muscle. In combination with the OLIF25 procedure, OLIF51 allows a surgeon to access levels from L2 to S1 with the patient in the lateral decubitus position. The OLIF51 access system is a retractor system optimized for the OLIF51 procedure. The patient is placed in the right lateral decubitus position, close to the front of the surgical table. The C-arm is posterior to the patient and may need to rotate at the base to obtain a true AP and lateral fluoro image. An oblique incision is made between these lines, 1 to 2 finger widths from the pelvis, to avoid the iliohypogastric and ilioinguinal nerves. Dissect through the fascial layer to expose the external oblique muscle. Continue the dissection to reveal the internal oblique muscle. Retroperitoneal dissection and exposure is performed using a finger or blunt instrument. It is helpful to push a finger straight back to the iliacus muscle, then move posterior to the psoas muscle to ensure the peritoneum is released. Feel the medial border of the common iliac artery, then the disc and sacral promontory without mobilizing the common iliac artery and vein. A wide rostral to caudal development of the retroperitoneal plane is worthwhile to maintain the attachment of the ureter to the posterior peritoneal wall. Continue the dissection while searching for the common iliac artery pulse, with appreciation that the common iliac vein is just medial to the artery. Adventitial layers on the anterior disc should be mobilized using gentle blunt dissection. Carefully position a blue vessel retractor blade under the iliac vein to protect and retract the left common iliac vein and artery. The blade is designed to allow direct visualization when a pin is malleted or screwed into either the L5 body or the sacrum. Place the green Holman retractor medially with the distal tip wrapping around the contralateral side of the disc space. A suction device may be used through this retractor. Finally, another blue vessel blade is placed at L5 to protect the bifurcation. The flexible arm retractor system can be fully tightened to hold the blades in place. Alternatively, it can be used in combination with stability pins to provide a semi-rigid system that facilitates minimal tissue pressures on the surrounding abdominal structures and provides greater degrees of movement for the surgeon, permitting a more minimally invasive exposure. With the retractors in place and disc exposed, it is helpful to mark the midline of the disc space. Perform an annulotomy and discectomy with constant awareness of the approach obliquity. Lateral fluoroscopy can be used to determine where the tools are with respect to the epidural space. The OLIF51 procedure enables the surgeon to insert an interbody device with a large footprint. A plate can be added for fixation,